sorry. So we conducted the analysis on comprehensive meta-analysis. After that, we are gonna go to analysis. Here you can see the meta-regression. We are already done with the meta-regression. Now, one thing is Egger's test. In our slides, there was this thing Egger's test. Egger's test is also used to find out the publication bias. Dr. Aditya told you things about the funnel plot. Funnel plot is basically a vague way to tell you if your study has, if that study has publication bias or not. But Egger's test gives you a p-value, and you know how to interpret the p-value. Is just the same. Less than 0.05, you have significant publication bias. Greater than 0.05, you have not significant publication bias. So Egger's test can be done on software like Stata and comprehensive meta-analysis. Again, it is not necessary. This is just an additional test. Stata is a paid thing, and comprehensive meta-analysis, we can get the trial version of it. So I'm gonna demonstrate you how to conduct Egger's test on just with 2 clicks. We will be done with Egger's test. So we were here. Let me go back to data entry. So we pasted the data here, and then we went to analysis, run analysis. We got the main analysis here, the forest plot thing. Change it to the random. Now again I will go to analysis. As you know, Egger's test is a part of the publication bias thing. So I will go to the publication bias, and then I will click this thing, the one the bullet near the table here, and now I will click it, and now I will just click it. So this button, and it will show me some different tests. What is our nearest Egger's regression intercept? What I did, this was my main analysis. I went to analysis. I went to publication bias. I will just click this table here. So I will click, and after getting Egger's regression, I will stop. So in Egger's regression, this p-value is the most important thing, and it determines whether the study has publication bias or not. This is just another thing instead of the funnel plot. So again, you are only going to do it if your study basically has greater than 10 studies. So this p-value, you guys interpreted this for me. Less than 0.05 means significant publication bias. Greater than 0.05 means not significant publication bias. So seeing this two-tailed p-value, you are always going to see the two-tailed p-value. Seeing this two-tailed p-value, kindly interpret this for me. If this study, this core analysis has publication bias or not. Is the publication bias in this study significant or not? Everyone? Not significant. So you're gonna mention it in your manuscript that you conducted an Egger's regression test and your p-value was found out to be 0.1, which showed non-significant publication bias. That's it. You are done with Egger's regression. That's how you are gonna add Egger's regression test in your manuscript. So everyone got this thing? Is my voice or just a second, let me change my internet connection. Is it audible for everyone else? Is my voice alright? So I guess my internet is okay. So this is what Egger's regression tells you, that if your study has significant publication, then this p-value will be less than 0.05. If it is greater than 0.05, like in this scenario, when the p-value is 0.18. So you will mention it in your manuscript that you conducted to assess the publication bias. author का नाम लिखते हैं basically. Author 1 and author 2 conducted Egger's regression test, and the p-value was found out to be 0.18, which basically shows non-significant publication bias. That's it. So this was an additional thing. It is done on comprehensive meta-analysis. How you're gonna go to the analysis, publication bias. If not appearing, if funnel plot is appearing, then you are gonna go to table, and you're gonna click it again and again until Eggers test appears. Two-tailed value, two-tailed p value. No, exactly. Revman only allows you to conduct the basically the to analyze the dichotomous outcomes and the continuous outcomes. It also gets you the funnel plot, but it does not get you the meta regression or the Eggers regression. So yeah, that's why we use comprehensive meta analysis for it. Yes, you can do it anytime you want after meta regression. No, it is not necessary. It is not necessary. It will simply run on the. It will run without it. If we clear this thing, so yeah. I'm gonna go to analysis. I cleared out the mean edges. So yeah. Then again analysis, publication bias. You can see the p-value will remain same. It does not require the covariate. Ahmed, I told you that how to add the p-value in the manuscript. So yeah, I told you how to add the p-value in the manuscript. That is, you're gonna write it in the manuscript that author 1 and author 2 conducted an Eggers regression to assess the publication bias. P-value was found out to be 0.18, which shows non-significant publication bias. This is how it looks like. You will mention it in the plot. Hamza, here it is your funnel plot. It is a vague way of assessing the publication bias. It's enough. It's enough. If you do Eggers test, your manuscript will become impressive. So yeah, so do you want me to repeat Eggers test? All right. So Eggers test is also a way of assessing publication bias. It gives you the p-value. You're not gonna do anything. You are gonna enter the data on your comprehensive meta-analysis or Stata. Stata is a paid software. I don't have it. Comprehensive meta-analysis, you can get the trial version or you can get the full version as well. So yeah. So when you are done with you adding the data, you are gonna go to the analysis, run analysis, and then you are gonna go again to the analysis. First of all, let me change it to the random. Again to the analysis, the publication bias. Here, if Eggers regression intercept is not appearing, you are gonna click the table. It will appear. So yeah, and you are gonna interpret this p-value only. This p-value. Let me highlight it here. Only this thing. You're not gonna see any of this thing. Just this p-value needs to be mentioned in the manuscript. How you are gonna mention it? You are gonna say that author 1 and author 2 conducted an Eggers regression to assess publication bias, and the p-value was found out to be.
I think there's a problem with Dr. Shariar's internet. He has actually left the chat, the meeting. Okay, guys. So the problem was that okay. So we were discussing Eggers test, right? The thing about the Eggers test is that the funnel plot, whenever you have more than 10 studies, the funnel plot has to be added into the supplementary document. Okay, but Again, if you have open meta-analysis available with you, then you can also do eggers. Okay.
Comprehensive meta-analysis, Dr. Radia, comprehensive. We cannot conduct aggregates on open meta-analysis.
Comprehensive meta-analysis. Okay, so Dr. Shah, you can continue.
Sorry for the interruption. Thank you for Dr. Radia. Actually, my net is not working very well. So let me share my screen again. Is my screen visible?
Yes, it's visible.
All right. So as Dr. Raja explained to you, why do we conduct an aggregate regression? Now I'm going to show you how to conduct a single arm meta-analysis. You might never came across a single arm meta-analysis in your research journey, but it is possible that you came across it. So it's better I will just show you briefly how to conduct a single arm meta-analysis via open meta-analysis. So open meta-analysis is a free software. You can get it from the Google. You can download it.
Dr. Sharia, I think you disconnected after the Eggers test.
Yes, basically I was telling them how to report your Eggers test in the ministry. You can speak, Dr. Radhu.
You just mentioned the value of the Eggers test in the discussion part. I will show it to you guys that how do you mention it in the discussion part. And over there you mentioned that the Eggers value was significant or non-significant for the publication bias. Okay. I will show it to you that how do you report in the manuscript in the discussion section. Okay.
Right. Thank you so much, Dr. Radhu. So this is what an open meta-analysis look like. So yeah. So first of all, in order to conduct a single meta-analysis, what are you gonna do? You're just gonna create a new project. Clicking, we are just gonna click create a new project. So now in single arm meta-analysis, do we have two groups or one group? Can you guys tell me? Whenever we are conducting a single arm, exactly, we have just a single group. We do not have a control group. Right now, I'll show you. Let's get an example of patients who underwent thyroid surgery, and we are gonna assess the bleeding risk. So yeah, bleeding rate in them. We are gonna assess bleeding risk in patients who underwent thyroid surgery. This is an example of there might be possible that multiple trials are conducted on patients with thyroid, patients who underwent thyroid surgery, and the trials will assess the bleeding risk. So if multiple trials are on this topic, so I am able to conduct a single arm meta-analysis on this topic. Say similarly, a medication for hepatitis is first bower. So yeah, those patients with hepatitis, my intervention will be first bower. There will be no comparator group. My outcome will be incidence of dysuria. So basically, in this example, I'm gonna assess the incidence of dysuria in patients who took surface bower. Are you guys getting this point? When should I conduct a single arm meta-analysis? So yeah, so I'm gonna demonstrate you on data of some imaginary data regarding thyroid surgery and the bleeding risk for different trials. So exactly, the included articles will have no comparator group. For that, I'm gonna select this thing, one piece of data from each study or studies within one group. So you guys tell me which one should I use? Is mean for dichotom? First of all, tell me the bleeding risk, events and total. Is this outcome dichotomous or continuous? Dichotomous. For dichotomous outcome, what should I use? Proportion or mean? Proportion is ratio basically. Exactly. Irfan, I will use proportion. As you know that mean is used for continuous outcome. Malaika, we will explain what phase 2 trials and single arm studies are in later. So yeah, so let's keep your concentration with here. So yeah, so you are gonna click proportion here and then click next. in the metric section, you're always gonna use PAS, accent transform proportion. So yeah, you are gonna use this always, always, always. So yeah, you chose a metric to PAS, accent transform proportion. Then you are gonna click next. What is their outcome name in the thyroid surgery? Can you guys type in the chat box? Or outcome name? Can you guys type in the thyroid surgery bleeding? Basically, I want to assess the number of patients who got bleeding after thyroid surgery. I'm just gonna click finish. You guys can see the study name here, group A events, group A total. I just said the those things, the proportion thing, and the PAS arsine transform metric transform proportion, and then I will click finish and this will appear on my screen. As you guys know, this is a single arm meta-analysis, so group B total are blackened here. So yeah, we just have to enter the study name here, group 8 event, group A total. Now for example, Irfan conducted a study. So yeah, I'm just gonna use the last three names in the chat. Mariam conducted another study. Uneza conducted another trial. So yeah, in the year 2021, 2022, 2023. This is just imaginary data. So yeah, I'll show it to you, Amama, once again when I'm done with the analysis. So yeah. So in Irfan's study, the total number of participants was 350. This total is the patients who underwent thyroid surgery, and the events will be for suppose 25 of the patients who underwent thyroid surgery got bleeding. In Mariam the study, 400 was the total population. 38 was the number of patients who got the bleeding in thyroid surgery after thyroid surgery. Unaiza's study contained 250 participants, and the number of patients who got bleeding was 29. This is how I am gonna enter the data specifically for each study. You're gonna enter the study name manually, enter the study year manually, and then the events and total. Event says you're bleeding right now, and the total is your thyroid surgery population who underwent thyroid surgery, patients who underwent thyroid surgery. Now, where should I click? Out of these all buttons, where should I click? Does any one of the this icon is any icon similar to the forest plot? Is any icon here similar to the forest plot? Near red, exactly, the black one. So what I'm gonna do, I'm just gonna click this black button here. I'm not gonna do anything here. I'm just gonna click OK, and it will show me the forest plot for single arm meta-analysis. Let me zoom it in for you. So this is what a single arm meta-analysis forest plot looks like. Here you can see all these three studies. This is not the ratio, the risk ratio or the odds ratio or anything. It just tell you the estimated, basically estimate of bleeding risk. So yeah, so you can change it into percentage, which will be 9.2%. So in single arm meta-analysis, you basically tell the reader that patients, after pooling all these trials on patients with thyroid surgery who underwent thyroid surgery, bleeding risk was found to be 9.2%. That's it. This is the confidence interval. You will mention this thing, and you will add this forest plot in your single arm meta-analysis. Does this forest plot look good, or the Revman one? You guys tell me. Does this forest plot look good? Exactly. That's why we use Revman. It's better to interpret. The diamond is better. Everything is better. The heterogeneity looks appropriate. It is basically the Revman's forest plot is self-explanatory. So yeah, heterogeneity here you can get it. Yes, kind of. Yes, kind of. Alicia, you can get basically the prevalence of anything like headache frequency. You can get it for one group, just for a single group. We cannot conduct single arm meta analysis on RevMed. So yeah, there is no concept of significance here. So yeah, you will just tell the readers. Here you get the p-value, but it is for this I square. So yeah. All right, Anaya, let me review it for you. Someone was asking to do it again, so I'm just gonna copy this data. Let me make a. But it's appropriate to conduct an analysis of cross-sectional studies using SPSS. So yeah, SPSS will was taught to you guys in the level 1. No, we haven't heard of prevalence meta-analysis, Ahmed. So it's better to calculate the prevalence or the cross-sectional study to analyze it using the SPSS. SPSS is much better software than open meta-analysis. So yeah. So what are you gonna do? First of all, for single arm meta analysis, you're gonna go to one group. One group, may if you have dichotomous data, you will select the proportion. If you have continuous data, you will select the mean. For right now, we have dichotomous data. I selected the proportion. The metric will be always set at PAS, per arcsine transform proportion. Then I'll click OK. Our outcome will be bleeding. No, right now we cannot use SPSS for meta-analysis, but in the later update, it might be possible that SPSS is able to conduct a meta-analysis on it. So yeah, I'm just reviewing it. You asked me to review it, so I was just reviewing it. All right, so I will always, for a single arm meta-analysis, dichotomous outcome, I'm always going to use proportion. For continuous outcome, I'm going to use mean. For proportion, I for dichotomous outcome, I'm going to use proportion. I'm going to click next. This will always be set at PAS, per arcsine transform proportion. Then I'll click next. Our outcome name is bleeding after thyroid surgery. So yeah. Then I'll click finish. This screen will appear here. So yes, so I need to mention only the data for group A, as you know that the group B is your control group, but in single arm meta-analysis you do not have the control group, so it is already black. You are not allowed to enter the data here. So yes, so I'm just paste the data. I just pasted the data here. So yeah, these are the three trials conducted in these years. These are the total number of patients who underwent thyroid surgery in each of these trials. This is the total number of events, which means bleeding in these trials. Bleeding occurred in 25 participants in out of 350, 38 out of 400, 29 out of 250. After that, you are just gonna click this button and beside the red thing, meta-analysis. You're gonna click OK, and forest plot will appear here. So how are you gonna interpret it? You're gonna interpret just this value, this 0.091, and this confidence interval. So yeah. So the overall bleeding risk is 0.09, which is 9.1%. This is how you conduct a single arm meta-analysis using open meta-analysis. It's better to use SPSS if you are conducting prevalence study, cap studies, or you are finding out the prevalence or cross-sectional study. So basically, I'm just converting this 0.09 into percentage, Amama. So if I'm gonna convert it into percentage, it will be 9.1%. So patients, I'm gonna tell the readers that I pulled these three articles. So yeah, and my bleeding risk was 9.1%. The pooled bleeding risk was 9.1%. That's it. That's how we interpret this thing. Ahmed, we do not conduct single arm meta analysis regularly. I haven't conducted one. I'm just showing you how to conduct one. Yes, we will always select PAS. Alicia, for prevalence meta-analysis, I haven't heard of it. You guys can Google it regarding the prevalence meta-analysis. For prevalence in cross-sectional study, it is recommended to use SPSS. Mariam, basically, how can you report it in the manuscript? You can Google, you can go through the PubMed and search the single arm study, single arm meta analysis, and you guys can have an idea how a single arm meta analysis manuscript looks like. Dr. Radia will tell you how to write how to write manuscript, right? How to basically manuscript, how manuscript is constructed for a double meta-analysis. Dr. Radia, on to you.
Yes, okay. I think we're done with the part now. I think
Basically, these were the additional thing. A single meta-analysis was an additional thing. If you came across any time in your life, you will be able to do it.
Yes, so basically now we're
That's
done.
why I showed you. We haven't conducted a single meta-analysis.
Yes,
up till
guys,
now.
it's usually meta-analysis is usually on double arm trials and double arm topics. Okay, we don't usually do it for single arm single arm studies. Okay, so now we're done with most of the part. Okay, till now again I'll briefly discuss what we have done initially. Can you guys tell me? Okay, we'll just have a quick revision of what we've done in 5 minutes, and then we'll hand it over to Dr. Hussain. Dr. Hussain, I hope you're ready, because now we're going to wrap up everything. Okay, so can you guys tell me what was the first step of meta-analysis? Quickly, guys, what was the first step of meta-analysis that we did on day one? Now it's a recap of the 4 days we've been having this workshop. It's a revision. Exactly, you find the topic. Second step is PICO. Third step is screening. Fourth step is third step. PICO के बाद third step is screening या फिर literature search. सही, exactly Uneza. After literature search, what do we do? Inclusion, exclusion. Excellent, Aruba. Then comes data extraction. Okay, yes, Irfan. After the inclusion exclusion comes data extraction. After data extraction, what do we do? Analysis. Excellent. Which software do we most commonly use for analysis? RevMan. Excellent. Okay. After analysis, what do we do? After analysis comes the difficult part. After analysis, now, yes, we do the manuscript writing, and before the, yes, risk of bias assessment. Excellent, Malaika, you remember the diagram. Then we do the manuscript writing, and then finally the submission and publication. After the analysis, we need to check the heterogeneity. We need to check two things. One thing, if our analysis has less than 10 articles or more than 10 articles. If we have more than 10 studies in our analysis, we go towards the funnel plot and the publication bias. If we have less than 5 studies, we will not do the final plot. Okay, Eggers is up to you. If you have the software, you can proceed towards Eggers. If you do not have the software, that's completely fine. But you have more than 10 studies, so then definitely you will make the final plot on RevMan. The second thing we check is for the heterogeneity. If the heterogeneity is less than 50%, your forest plot is good to go. You don't need to do anything about it. If your heterogeneity is more than 50%, if your heterogeneity is more than 50%, then we will proceed towards the possibilities of reducing the heterogeneity. Yes, first of all, our main aim is to see if we can make subgroups. Exactly, subgroup analysis. Sensitivity analysis will always be done. Okay, sensitivity analysis is done. After that, we will proceed. If we have our extra softwares, if we have comprehensive meta-analysis, then we will go towards the scatter plot. Yes, we will go towards meta-regression. Excellent. If we are, yes, excellent, guys. We will do the meta-regression. If we don't have comprehensive, we will not do meta-regression. Sensitivity analysis will always be done. After sensitivity analysis, we need to find the potential causes of heterogeneity. We can assess those causes using meta-regression. If you don't have comprehensive, that's fine. You will just mention that these causes might contribute towards heterogeneity, okay? And we will write in discussion. Excellent. So that after all of this, now we will proceed towards another step, which is risk of bias assessment. Okay, Dr. Hussain will explain us regarding risk of bias assessment. After risk of bias assessment, we will have all the risk of bias assessment, and the Prisma flow chart will be explained by Dr. Hussain. Those are the further prerequisites for our manuscript writing. Once we are done with these 2 to 3 additional things, our meta-analysis the material for our meta-analysis will be complete, and then we'll finally compile it in the form of our manuscript. We will then cover the manuscript writing, and then Dr. Hussain will proceed towards Prospero and the submission procedure. Okay. So now over to you, Dr. Hussain. You can start with the risk of bias assessment. Okay. Now, guys, we don't have a lot of we don't have a lot of work to do on these softwares. Now you guys can just relax a bit and listen to what Dr. Hussain is teaching. Again, this is a very important part, but you guys can understand it easily now. Okay, so Dr. Hussain, you can continue.
Just the theoretical part is left. No need to worry about anything. Just Dr. Hussain will tell you what are the types of bias, how to clear out bias in meta-analysis, and how there are some checklists known as Prisma checklist and Amstrad checklist. So, yeah, Dr. Hussain will tell you how to fill those checklists for meta-analysis.
Okay, so Bismillahir Rahmanir Rahim. Am I audible to all of you guys? You can comment in the chat box.
Yes, you're audible.
Okay, brilliant, brilliant. So first of all, thank you so much, Dr. Radia and Dr. Shahryar, for this amazing session. Almost 80% of our meta-analysis, components of the meta-analysis have been completed. So this few modules are remaining in our workshop, one of which is the quality assessment. So I will share my screen. Is my screen visible to all of you guys? I'll just open the slides. So is my screen visible to all of you guys? Okay. So first thing first, we will start with risk of bias assessment or quality assessment. These both are. I'll increase the volume. Okay, just a minute. Okay, now am I audible to all of you guys? Is it my voice? Is it lagging or is it not audible? Am I audible to all of you guys?
Yes, Dr. Hussain, your voice is completely.
Okay, brilliant. So first thing first, we've covered the major portion of the data analysis, the meta-analysis, statistical analysis test. One thing, this is a theoretical part we mention in our manuscript. So there are 4 components of the manuscript: the introduction, the methodology, the results, and the discussion section. So one part of the methodology and result section is the journal will ask, the reviewer will ask, did you do a proper quality check? Did you do a proper quality assessment? Did you do a proper risk of bias assessment of the articles? Now, in the beginning, we told you that there are 2 types of articles which we include in our meta-analysis or systematic reviews. One is the randomized controlled trials. The other are original article, the other are cohort studies, or they also goes by the name of non-randomized trials. So there are scales, there is a proper scale for both of these articles to assess the quality of the articles which we are including in our meta-analysis. So consider if we are including 5 articles in our meta-analysis, we are doing a meta-analysis, we have found 5 articles which are answering same research question, they have similar outcomes or primary endpoints, and now we have to assess if the articles, these 5 articles which we are including in our manuscript, in our meta-analysis, are these articles good quality? Do they have low bias? Bias means uncertainty. Now there are types of bias, but but we have to make sure that if we are including the article in our meta-analysis, it has been through a proper quality assessment, and it has a low risk of bias. If the articles have very high risk of bias, very high uncertainty, very high bias, so we might have to omit or exclude that article from our meta-analysis. Up till now, it is clear to you guys what is quality assessment. Brilliant. Now, there are 2 scales. One is Newcastle Ottawa scale. I won't say this is this. Just remember this name. Okay. So just remember these two names. The one is the Newcastle-Ottawa scale, and the other one is risk of bias. Risk of bias scale also goes by the name of Cochrane's tool for risk of bias assessment. Now, Newcastle-Ottawa scale is used to assess the quality of observational studies. Okay. And ROB tool, this also has a name of ROB tool, risk of bias assessment tool. It is for randomized controlled trials. Now, there are a lot of different tools such as JBI checklists, such as ROB2, ROB1, ROB3 tools. But the most common ones, the most common tools, the most common scales which we use or which the journal accepts are the Newcastle Ottawa scale, which is used to assess the quality of observational studies, and the Cochrane's tool for risk of bias assessment, or ROB tool for randomized control trials. Then why don't we do it in the start if ultimately we don't have to remove? Sometimes, Malaika, we don't remove it, but we mention it that the article has very high risk of bias, and during the peer review system, the journal, the reviewer says that this article has a high risk of bias. It would be good to omit that article. Then after that, we omit that article. So we don't decide it in the first place. Okay? But we have to mention which article has a high risk of bias and which article has a low risk of bias. Okay. So moving on. Now, these are in the form of Word documents. These are documents which you can download from your Google. They come in the form of a Word document. So, how does this document look? This is how the document is going to be. Jan. So, I will discuss, first of all, I will discuss the Newcastle Ottawa scale for cohort studies. It is for case control studies as well. It has there are other tools as well, but what I said, that Newcastle Ottawa quality assessment scale is the most common scale with the journal accepts when you are doing a quality assessment for cohort studies or observational studies. Now, it has a set of 10 questions. It has a set of 10 questions. I have made an explanation as well of these questions and how do you answer these questions like this. And if the answer is correct, if your article is answering that question with the scale has mentioned, you give it a star. There can only be total of 10 stars, I believe. 1, 2, 3, 4, 5. These are the 4 questions. Again, this is another question, the comparability. They come under an umbrella term. There are 3 headings. We assess the selection, we assess the comparability, and we assess the outcome. Okay, so first thing first. Now, there is a cohort study, the Newcastle Ottawa scale. Again, this is a tool used to assess the quality of non-randomized studies such as cohort studies. Okay, so first thing first, one thing, the first question that the scale asks is the representativeness of the expressed cohort. Cohort means a population. The first question would be it is this question: the representativeness of the exposed cohort. Is the expressed cohort the truly representative of the average in the community? Now, how do we understand this? Now, consider this question: if we are considering a study, it is a cohort study. Is the cohort study assessing a study? Now, consider this example. First of all, I will read this example. A study assessing the effects of smoking on lung cancer, where the exposed cohort is a random sample of smokers from a general population. Now, we are doing a cohort study. Consider this: we are doing a cohort study, and in the cohort study, we are assessing the effects of smoking on lung cancer. So, if the cohort, if the population we are adding in, if the population we are considering for that study is a general representation of the smokers, and we are randomly picking those smokers, that will be a true representation, and we will give it 1 star. So one question, we check for one question, and it got 1 star. Do you understand up till now? This was a question. This was the first question in the scale. It was asking if whether the expressed cohort is a true representative, or somewhat it is assessing the representativeness of the expressed cohort. The first question of Newcastle Ottawa assessment scale. So do you understand it up till now, or do you want me to repeat it? Okay, repeat please. Okay, I will repeat. there is a scale, there is this Newcastle Ottawa scale. It can be tricky. This is a theoretical theory portion, but you have to understand it. You don't have to go thoroughly or deeply. You just have to answer these questions. So you consider you have included 5 articles in your meta-analysis, okay? And there are 2 cohort studies and 3 randomized controlled trials. So you will pick the first cohort study. You will thoroughly read that cohort study. You will thoroughly go through the methodology section of that cohort study. So if it is not true, we will leave the question. It won't be a true representation. It must be a true representation, or it isn't. If it is not a true representation, it should be somewhat representative. Or if it is a selected group, or there is no description of the selection, you will mark the star according to that. Mariam, I will share these files in the group. But right now, I want you to be attentive. Consider that you are including 5 articles in your meta-analysis. Okay, Nidal, I gave you this example. Now, first of all, let me just explain it to you guys, and then I'll answer the questions, okay? Don't worry. This is a bit tricky, but I assure you that you will be able to understand it at the end of this module. So first of all, consider this. Consider that you are including 5 articles in your meta-analysis. 2 of those articles are cohort studies. Now we have to perform one step, which is a quality assessment. The quality assessment is done on individual articles. All of the articles go through this quality assessment check. Now, considering this article, I have picked one cohort study, and now I have read thoroughly the complete cohort study. Now, I have to make sure that I have done the quality assessment of that cohort study. Now, the first question of the quality assessment scale is this: whether the expressed cohort is a true representation or is somewhat representing the community, or it has picked a selected group, or there is no description of where they picked the cohort. Now this is the first question, okay? How do I know it? If in the methodology section the journal has mentioned that from where they have picked the cohort. Now consider this example that now if in a study in the methodology section they have mentioned that the study assessing the effects of smoking on lung cancer, the expressed cohort is a random sample of smokers from the general population. Now from the general population, it is a representation of the community of smokers. If it was considered another study, if in the study the expressed cohort, which were the smokers, were recruited from a health clinic or any specific clinic which is not the true representation of the general population, it will be a somewhat representation. But again, in the question, in the option C, selected group of users, for example, nurses. For example, in the study, we are picking the cohort which is a group of nurses who smoke. Those are smokers, but those are not the true representation of the general smoking community or the population. So it won't get a star. This has high bias, or there is no description of the from where we picked the cohort or the population or the study population of our cohort study. So this is a high bias alert. Do you understand it? The first question, the representativeness of the exposed cohort. You don't have to dig deeper, you just have to understand. Okay, brilliant. Now the second question. Again, all of these questions are addressed if you have gone through thoroughly, at least twice or thrice, the complete cohort, and this is performed on individually on each study. It's not like all 5 of studies have one quality check. If there are 5 articles, there will be 5 quality assessment checks of each article. So the second question, now I have added examples as well to make sure that you understand what true representation is. Okay, we just make a table. Star कैसे देंगे? ये Zona, you are asking star कैसे देंगे? We will just make like this. We will make let me tell you how we will make a table like this. We make this table, and inside this table we have added the blocks of the questions. Now if these are the studies: DUSIC, SADC, RISC, and BCC. So if this question is if these are 4 cohorts, and my first cohort study, DUSIC, is addressing the representativeness of the exposed cohort, I will just mark 1 star for this. we copy and paste this table in our manuscript, but this is how we make the table. Okay, first question, if any of these questions, if now going back to the checklist, if the representative, if the exposed cohort is a true representation or somewhat representation, we give it a star. We give it a star. But if it is not a true representation, or there is no description, or there is a selected group, we don't give it a star. More star means less bias. Less stars mean more bias. Yes, we make the table manually. Less star means high bias. Yes, exactly. If it is fulfilling all these questions, it means that the article has low bias. If it is not fulfilling all these questions, it means the article has high bias. Up till now, am I clear to you guys? It is a kind of boring part. It is kind of a theoretical part, but without this step, you cannot complete your meta-analysis. How do we star more options? We go through each of these 10 questions. If the article is addressing 5 questions, we give it 5 stars. If the article is addressing 10 questions, we give it 10 stars. The more number of the stars, the less bias and good article. Where do we get this from? We download it from internet. We'll share the PDF files and the Word documents. Okay, shall I move forward? Up till now, it is clear to you guys? Please, can you share the table? I will share the table, Anaya, on the group. Okay, you don't have to worry. So for the study, we can either star A, B, C, or D, right? Yes, exactly, Aruba. Moving forward, the second, again, the first question is for the express cohort. Or express cohort is like intervention cohort, the cohort, the population, or okay, someone please turn off the mic. Okay. Some participant has his mic turned on. Please turn it off. Okay. Brilliant. So first question is for the representativeness of the exposed cohort. Now, what about the non-exposed or the controlled cohort? You know, in a cohort study or in a randomized control trial, in a cohort study, there are 2 groups. In the one group, we give some drug, and in the other group, we don't give some drug. So the group or the cohort which is receiving the drug is called the interventional group or the exposed cohort. The group which is not receiving the intervention is called the non-exposed cohort or the control group. Okay. So if the how did the participant, how did the participants of the non-exposed cohort were selected? I am performing a cohort study. In the cohort study, I have to make sure I have answered this question. Okay? So if in the methodology section, the writers of that cohort study have mentioned how did they select the non-exposed cohort, again we will give them 1 star. So again, if they have drawn if the same community drawn from the exposed cohort, now these are the options. Now consider this example. Selection of the non-exposed cohort. Were the non-exposed cohort drawn from the same community as the exposed cohort? Now consider this. If I am in Sindh, and I am doing Sindh is a province in Pakistan, and I am starting this cohort study in which I selected the smokers from Sindh and the non-smokers from Punjab, that is another community. So will it be a good way to start my cohort? Again, it won't be, because I didn't draw the non-exposed cohort from the same community. I drew them from a different community. So we have to make sure that the exposed cohort and the non-exposed cohort is drawn from the same community. Not just me, the person who is conducting the article, who's conducting the cohort study. I am just assessing his cohort study. It is not my cohort study. I am supposed to include that study in my meta-analysis. So if I am including that article in my meta-analysis, I have to make sure that he has done his job correctly. Do you understand it up till now? So again, if consider you have found you have your meta-analysis, you are going to include 5 articles. 1 article is a cohort study. Now you went thoroughly through the cohort study. Again, you went through the methodology section, and in the methodology section, they have mentioned that the representativeness of the exposed cohort is a true representative, and they have selected the non-exposed cohort from the same community. Now, how many stars does this give to this article? How many stars will it give to this article? 2. Malaika is saying 2. Your answer is correct, Malaika. Omama is also saying 2. Again, brilliant. Brilliant. Third question. The third question is ascertainment of exposure. The third question is asking whether the outcome, whether the exposure or any intervention we gave, how did we make sure that, for example, we are picking a cohort, we are conducting a cohort study. So how is the cohort study, the records of the cohort study is done? Consider this example. Now we are on the third question, which is asking. Okay, I will repeat it. Now consider this question. This is the third question. This is the third question of our Newcastle Ottawa scale. It is asking whether the ascertainment of exposure. Now we are. Is the star only for option A? Yes, option A. Agar ho raha, if the question is answering the option A, we will give it a star. If in question number one has star for option A and option B. So if is the exposed cohort a true representation or somewhat representation of the community, we give it a star. If the non-exposed cohort is drawn from the same community, we give it a star. Okay, depends on the question. Again, yes, Malaika is getting a grip on this Newcastle Ottawa scale. Now, my third question is, how did we conclude that if we are including participants in our cohort study, so was the exposure now consider this, the exposure was smoking. So how did we made sure that the participants were actual smokers? If my exposure, ascertainment of exposure means that we made sure that the exposure which is smoking in, suppose that is smoking in my study, we made sure that the person was actual smokers. So did we check secure surgical records or any medical records? Did we conduct a structured interview? Did we did a structured interview and made sure that the person is a smoker, or did we have a medical record of that person which made sure that the person is a smoker? If these two options are present, if these two points are present in the methodology section of the exposed cohort, then we will give it a star, because now we know that the ascertainment of exposure is made sure by a secure record or a structured interview. But if we included the participants in our cohort study and they did a self-report, like we shared a questionnaire, and the participant himself mentioned whether I am smoker or not, so we cannot rely on that ascertainment of exposure which is smoking, so we won't give it a star. Or if there is no description of, if they made sure that the ascertainment of exposure was made sure, we won't give it a star. So if these two options are present, if any of these two options is present in the methodology section of the manuscript, we will give it a stars. Okay, up till now, do you understand this? How do we make sure? Now, I am giving you example. So in the study, smoking status is confirmed through medical records or a national health database. It means that the secure records were maintained. If we did a smoking status is confirmed, is determined through a structured interview with the participants. Again, this is a structured interview, we will give it a star. But if the participants provide their smoking status through a written questionnaire, we won't give it a star. If the study does not describe how the smoking status was determined, we won't give it a star. Up till now, these three questions are cleared. Do you understand it? Okay. We are doing this individually for each study. Yes, it will. Whenever we do it individually for each study, it will take some time, but again, it is an important step. Again, the fourth question is demonstration that the outcome of interest was not present at the start. I didn't, Nidal. Okay, I'll explain it again. The question 3 is making sure that there is proper ascertainment of the exposure. Now, if the exposure is smoking, ascertainment of exposure means if the participants we are including in our exposed cohorts should be smokers. Now, how will we make sure that those participants which we are including in our cohort study are smokers? One thing we can do is if we there are secure medical or surgical records which is stating that the person is a smoker, then this is a proper ascertainment of exposure. If we conduct a structured interview, if in the manuscript of the cohort study it is mentioned that the reviewers, the authors did a proper structured interview to make sure that the participants are smokers in the exposed cohort. Again, this is a good way to ascertain the exposure. But if the option is written self-report or no description, this means that the proper ascertainment of exposure was not maintained. This won't give it a star. Do you understand it now? So if we give A and B both a star, means we used both surgical records and a structure. No, the most likely the reviewers would use one method, whether they use a structured interview or they did a secure surgical or medical record. How will we know which option can be given to a star? You read the methodology of the cohort study which you are about to include in your meta-analysis. Somewhere in the methodology or in the limitations or in the discussion section of the study, it is mentioned how did they make sure whether there is a selection of non-exposed cohort, whether there is a true representation of the exposed cohort. All these questions are addressed somewhere in the manuscript. If they are not addressed in the manuscript, you just say there is no description, we won't give it a star. Up till now, it is clear. Okay, the azan is going on. I will take 30 minutes break, 30 seconds break, not 30 minutes, because azan is happening. I'll just pause one minute. Okay, Mariam has asked a very good question. Why are we giving no star if the study included a written self-report? Why aren't we giving a star to C? Because again, if we are following the Newcastle Ottawa scale, there is no star for option C or option D. There are only stars for option A and option B. See, Mariam, if we are following the Newcastle Ottawa scale, there is only a star for these two options, no star for this written self-report. Now, again, the fourth question is the demonstration that the outcome of interest was not present at the start of the study. Now, if we are doing this cohort study in which we are assessing the association of smokers and non-smokers with lung cancer, so we have to make sure that in the smokers, the smokers don't already have a lung cancer, because again that will mean that the demonstration of the outcome of interest was already present at the start of the study. See, I will explain this question again. So, example, participants are confirmed to be free of lung cancer at the beginning of the study through medical examination. Or if the study does not check whether the participants had lung cancer at the start. Again, this is the question. How much stars need to include less bias? Depends, they haven't set the number because again they have mentioned that the more the stars, the less the bias, the less the stars, the more the bias. But we cannot say that a certain number of stars will make this article more biased or less biased. Again, the fourth question is that demonstration that the outcome of interest was present at the start of the study. If consider this example, if in a cohort study there is mentioned that the participants are confirmed to be free of lung cancer, then lung cancer is our outcome. It can be any outcome. So if we are considering this study in which we are assessing the association between of smoking in smokers and non-smokers with lung cancer. So if the lung cancer is already present at the start of the study, this means that the outcome of interest was present at the start of study, and we won't give it a star. So how would we say it is less biased? We don't say it as less biased or more biased. We just mention it. We just mention that table, and the reviewers and the journal to which we are submitting the article assess them individually. It is their job, not ours. Our job is to address it, not explain it. Right, Anaya? Shall I move forward? Now, these are the 4 questions of selection. Up till now, is it clear to you guys? So how would we say it's less bias or more bias? Again, we don't have to say, we just have to address it. Okay, in which section do we add this table? I will tell you in which section do we add this table. Just we add it in the result section. We give it a heading of quality assessment or risk of bias assessment, and in that we mention this. I will Dr. Radhya, when she's teaching you the manuscript writing, she will tell you where to mention it. Okay, Fatma, she is asking to repeat it. Okay, I will repeat it, but please be attentive right now. Okay, the Newcastle Ottawa scale has 10 questions. There are 4 questions in the selection. If we are adding 5 studies, if we are studying if we are including any studies in our meta-analysis, which are cohort studies. So cohort studies go through a quality assessment, and we follow this scale. This scale has 10 questions. We thoroughly go through the manuscript, the cohort study, which we are about to include in our meta-analysis, and we see if the manuscript has answered these questions. Now, the first question is the representativeness of the exposed cohort. If it is a true representation, we give it a star. If it is not somewhat a representation of the community, we give it a star. If the non-exposed cohort is drawn from the same community as the exposed cohort, we give it a star. Ascertainment of the exposure, we make sure that the exposure, if it is smoking or any other exposure or intervention which we are studying, if it is made sure that the participants are having that exposure, or is it smoking, if it is made sure through surgical or medical records or a structured interview, we give it a star. If the outcome of interest was not present at the start of the study, which is lung cancer, if in this hypothetical study, we give it a star. So we check I put this manuscript or this cohort study at one side and put these set of questions at one side, and may thoroughly go through the manuscript first and see if all these questions which is mentioned in this scale are answered or not answered in the following manuscript. Up till now, it is clear. These sample questions are already present. We will just give it a star, not make questions exactly. Irfan, this is a pre-made questions. You just have to read the questions and make sure if the study which you are about to include in your manuscript is answering these questions or not. Up till now, it is clear. This is a tricky part. Quality assessment is a tricky part, and again, it is not performed by just one but 2 authors. So up till now, it is clear. We will share these questionnaires in the group, and these are universal questionnaires, which is most likely if you are doing a meta-analysis and you are including cohort studies, most likely the journal will require you to present a Newcastle Ottawa scale if this article has majority of cohort studies. Up till now, am I clear? So we will proceed further. Okay, brilliant. Please turn off your mic, Alicia. Okay, the other question is the comparability. If the study controls for the most important factor, we do this only for cohort. What about other studies? There is a different scale for randomized control trials. After these slides, I will share them as well, and we'll discuss them as well. One question can be given multiple stars. depending on the question. Yes, if the see now if this question has two options, if both of these options are present, we will give it 2 stars. If both of these options are mentioned, we will give it 2 stars. But it I'm not sure whether it this question can get 2 stars. Okay, it is rare. Again, it depends on how obediently and how meticulously the authors have performed their study. If the authors have done a great job and has followed all the protocols of the cohort study, I'm sure that the scale, when you are assessing that manuscript for this quality assessment check, it will have the majority of the stars. Do we have to attach this questionnaire? No, we make a table. Now see this table, it has all the questions and we have gave 1 star. Just a table would be enough. Thank you, Irfan. So we will move forward. Again, it is a tricky part, but I want you all of you guys to be attentive. Okay. So again, this heading has one question: comparability of cohorts on the basis of design or analysis. I will explain it to you thoroughly. Consider this. Now this has two options. Option A is the study controls for dash. Now it is the most important factor. Now if the study has controlled for age, for example, age is the most important factor, or sex or gender is the most important factor in this study, in this cohort study that I am performing on smokers and non-smokers and lung cancer. So if I have controlled for age, so how have I controlled for age? I have not only added the adult population, and I have also added the adult population in the non-exposed cohort. So I made sure that the study has controlled the most important factor. Now if in the expressed cohort I have added men and women, and in the non-exposed cohort I have added only women, or majority are women, now this shows that I haven't controlled the most important factor of the study, and this won't get me a star. Do you understand it? All these questions, the answer to these questions are mentioned somewhere in the methodology section of the article which you are about to include. Can you please explain the exposed and non-exposed? Okay, I'm giving you this example. Now consider this example. The study has controlled for age, ensuring, if in the manuscript you found a statement like this, that the study controls for age, ensuring both the exposed and non-exposed cohort have similar age distribution. What do you think? Shall we give it a star or not? Yes. Okay, brilliant. And if the study has controlled for any additional factors, such as besides age, gender, or socioeconomic status, shall I give it a star? Yes. Again, both these questions can get, this heading can get 2 stars. Okay. So if in the methodology section this thing is ensured, the comparability is ensured, this will get 2 stars. Shall I move? This is for the easy subsection, namaz break. Mama, I can't give you a namaz break right now. We have to complete this section. By the way, what's the difference between exposed and non? Naya, exposed is something which intervention and control. In the PICO section, Dr. Shariar might have told you that the PICO, there is intervention and control. So the exposed group is interventional group and the non-exposed group is a control group. These are interchangeable terms. Shall I move forward now? Okay, now it comes to the outcome. So if the outcome, now how do we assess the outcome? If it was an independent blind assessment of the outcome, we give it a star. I will explain all of these things individually. For right now, just follow with me. If the assessment of outcome was independent blind assessment, we will give it a star. If the assessment of outcome was through record linkage, we will give it a star. Again, if it was self-report, we won't give it a star. Again, if there is no description of how the outcome was assessed, we won't give it a star. Now consider this example. in the methodology section of the article which you are about to include in your meta-analysis, there was this statement that lung cancer diagnosis is confirmed by an independent blind radiologist. This doesn't mean blinded radiologist. This doesn't mean the radiologist is blind. It means that the radiologist didn't know which patients. He didn't have the names of the patients. He just had the records of the patients. Okay, so if most of you guys do know this this word which is used in most studies, single blind, double blind, and triple blind. Do you know what does that mean? Double blinding, triple blinding. So again, double blinding, triple blinding, these are blinding techniques in which the patient doesn't know which medication he's taking. The doctor doesn't know which medication he is giving to the patient. Is it a medication or is it a placebo pill? So if this blinding technique is ensured, we will give it a star. Single blind patient doesn't know, double blind, both the patient and the doctor doesn't know. Exactly. Thank you so much, Mohammed Irfan, for explaining. Again, there is a terminology called triple blinding. Neither the assessors know, neither the data analysts know. It is called triple blinding. But again, this is a blinding technique. And the statisticians too for the triple blinding. Again, yes, Aruba. So if there is an independent blind assessment of the outcome, we will give it a star. Isn't that harmful to patients? No, it isn't harmful to the patients. Now, Ahmed, consider this example. There are two groups. One is exposed group and the other is exposed group. Now, we won't tell the patients that you are in the exposed group or you are in the exposed group. Neither the patients know nor the doctors know. So neither the doctors know if they are assessing the results of the exposed group or whether the unexposed group. This way, the bias will be very low. Do you understand it? Okay, brilliant. Again, if there is a statement in the manuscript, lung cancer outcomes are obtained by linking study participants' data with cancer registry. Again, if there is a proper record or database linkage, we will give it a star. Some patients we are giving actual medication, some patients we are giving sugar pill just to know action of the drug. Exactly. I think Muhammad Irfan has got a good grip. Again, the part of this in randomized controlled trials, it is properly ensured. Some cohort studies do this step, some cohort studies don't do this step. But again, if they have done this step, we give it a 1 star. If they don't, we don't give it a star. So if for example, consider this example, if the participants during the assessment of the outcome, the participants self-report if they have been diagnosed with lung cancer or not, will we give it a star or not? No. Okay, brilliant. If the study does not describe how the lung cancer outcomes were assessed, will we give it a star or not? If the smoking status in the study we are about assessing, the smoking status is determined through a structured interview with the participants, will we give it a star or not? Okay, brilliant. Now I think you are getting the hang of this Newcastle Ottawa scale. Again, what you have to do is you have to go thoroughly read the manuscript. Again, you have to now compare the manuscript with the questions and answer these questions. Do you understand it up till now? Okay. The second question in the outcome is, was the follow-up long enough for the outcomes to occur? If a proper follow-up and a long follow-up, it can be long follow-up, it can be short follow-up, depending on the study, depending on the outcome. So again, the reviewers or the authors must know that there is a sufficient follow-up for the article we are conducting research on. If we did a study and the follow-up time was 1 week for lung cancer. Now, all of you guys know that lung cancer doesn't develop in 1 week or 2 weeks. So this is an improper follow-up time. Now, if the follow-up time was significant, maybe 1 year or 5 years, now that is a sufficient follow-up time for the study. So if the follow-up time was long enough, we give it a star. If it wasn't, we don't give it a star. Do you understand it? This was a very easy question. Do you guys understand it? You have to comment in the chat. Okay, brilliant. The final question is the adequacy of the follow-up of the cohorts. Were there complete follow-ups? if all the participants included in the study had proper follow-up. Now, during all of you guys know that cohort studies are long studies. They require, they are at least it takes around 1 to 2 years to complete a cohort study, and most patients don't follow up, don't give proper follow-ups. So if there is a complete follow-up, we give it a star. If the subjects are lost to the follow-up, it depends on how much percentage of the participants lost to follow-up. If there is a significant follow-up, if greater than 50% of the patients lost to follow-up, I will read the question. It can cause attribution bias. Yes. Subjects lost to the follow-up unlikely to introduce bias. If the subjects lost to the follow-up, they didn't create any bias. If it is a very small number, consider 2% of the patients lost to the follow-up, then we won't take away the star. We will give it a star. But yes, and I'll give you a break after this slide because again these are very comprehensive. We have to complete it quickly. But again, if there is proper adequate follow-ups, and if the patient didn't lose to follow-up, we will give it a star, and if they didn't, we won't give it a star. So this is how you assess. This is how you assess the quality of cohort studies. And what you do, you simply now see this. I will just open. Now you make a word table. You make a word table, and you mention that the I'll just show you an article which has address now this main manuscript. Now inside this manuscript, this is a meta-analysis. Now inside this manuscript here, risk of bias assessment. Though there is a heading of risk of bias assessment, the quality assessment of RCTs was done by this tool. The quality assessment, the risk of bias assessment included 5 articles. This. And this is how we this is the quality assessment table for randomized control trials. But again, for the cohort studies, this is how you mention it. You do a description of what you found, what were the most questions which most of the studies didn't address, or what was not. But this is how you include it in the manuscript. Up till now, is it clear? And we will move forward. I'll do the ROB tool very quickly. But up till now, is it clear to you guys? Yes. Okay. Brilliant. Now again, this. So this was a difficult part, but I assure you that the ROB tool will be much easier. Show all the questions of the word file question with examples. Show all question of the word file. Hamda, don't worry. I'll send the word file in the groups. You don't have to worry. You can simply find it on Google as well. So moving forward now, there is Cochrane's risk tool for risk of bias. Now it has many bias such as selection bias, allocation bias, performance bias, detection bias. I will individually go through all of these. When you are assessing, when you are checking the quality of a randomized control trial. Now all of you guys know that randomized control trials have a very robust methodology, but even after that, there can be bias. So shall we start the ROB tool for quality assessment of randomized controlled trials? Are you guys with me? Okay, brilliant. I'll just sip some water because okay, just Sonia is ready and Amama is ready. The rest of you guys, are you guys sleeping or what? Okay, so okay, brilliant. Can we do it after Maghrib? Afridi Azan, we will have to, I'll give you a namaz break after this. 10 minutes. Just give me 10 minutes, and after 10 minutes, we'll do a namaz break, okay? Just 10 minutes, 10 more minutes. Now, the first question. Now, thank you so much. Again, thank you so much, guys, for cooperating. I will give you guys a namaz break after 10 minutes. Just for 10 more minutes, I will explain the risk of bias tool for quality assessment. Now, in the randomized control trial, we check selection bias, we check performance bias, we check attribution, reporting, detection bias. All of these, I'll just give you a small example. Now, what is selection bias? Again, is the sample representative of the population? Allocation bias, how participants get assigned to the treatment group. Now, I want all of you guys to pick up a paper and pen, to pick up your notebooks, because again, the slides I will be sharing in the next few slides are very high yield, and it will help you a great deal if you note it down right now. Okay, Maghrib time is over. Okay, we gave, I think for 10 more minutes. Okay, 10 more minutes and we will start. Okay. So, first of all, the first thing which we check in our randomized control trial is the selection bias. Now, two subheadings come under the selection bias. One is random sequence generation, other is allocation concealment. Now, what is random sequence generation? If the process of assigning participants to treatment groups the process of assigning participants to different treatment groups or conditions in a way that is purely random and unbiased. So in the randomized control trial, you know that there are two groups. Now, how do you decide which participant will go to which group? So there are methods which are low risk and there are methods which are high risk. If the participants, the random sequence generation was done through random number table or computer generator or stratified or block randomization, I don't want you to understand all of these methods, but you make sure that you know what these methods are. In the randomized control trial, exact statements will be given. If the random sequence generation was done with random number table or computer generator or stratified or block randomization or minimization or these techniques, coin toss, shuffling cards or envelopes, these methods are low risk. But if the random sequence generation was done through date of birth, day of visit, ID or record number or choice of clinician, it is a high risk for random sequence generation. Do you understand it? It can be a tricky, but I want you guys to pay full attention. Do you guys understand it? Okay. If these methods are mentioned in the methodology section of the randomized control trial, these are low risk. But if these methods are mentioned, these are high risk. If you are having trouble with noting it down, just take a snapshot of this slide. It will help you. Later on, we don't allow taking snapshots of our slides, but I would recommend that you note it down because these will help you a great deal. Okay. The second step is allocation concealment, keeping the treatment group assignments hidden or concealed from both the researchers and the participants. Now we have to make sure that neither the researchers nor the participants know. Conceal mean to hide. Allocation concealment, keeping the treatment group. If, for example, suppose that we are testing a new drug, it has some benefits and some outcomes and some adverse effects. Now, if in the trial my family member is included and I know which treatment is given to which group, I will make sure that my family member don't get that treatment because it might have some unpleasant effects. So this is how you break concealment. You break allocation concealment. Whenever you are performing a randomized control trial, you have to make sure that the proper allocation concealment is maintained. How do you do it? By double blinding and triple blinding. Okay. So if in the methodology section, central allocation is used for allocation concealment or sequentially numbered opaque envelopes or sequentially numbered identical drug containers, these methods, now identical drug containers or in the envelopes which the medicine is contained, these are identical sealed envelopes. That way, neither the participant nor the researcher will know which envelope has the medication or which container has the drug. This is how you maintain low risk. But if the random sequence is known to the staff, or if the envelopes or packaging without any safeguard measures is used, this is how you break the allocation concealment. So if these two questions are addressed, you will give it again. It will be high risk. Now in the Newcastle Ottawa skill, we will giving stars. In this, we mention high risk or low risk. Up till now, am I clear to you guys? I will give you examples of how you find it. Okay. Again. Now this performance and detection bias. These all also come under one heading. High risk of bias means high bias, high uncertainty. Low risk of bias and means low risk, low uncertainty, good evidence. Okay. Whenever the bias is increasing, the evidence is decreasing. Now in the performance and detection bias, again, this step is for blinding of participants and personnel. Have you made sure that the participants are blinded? Have you made sure that the researchers are blinded? If the blinding and unlikely that the blinding could have been broken, if there is no break in the blinding, it is low risk. If there is no if no blinding has happened and incomplete or broken blinding has happened, again the blinding of participants and personnel is very important in the randomized control trial. If it is broken, it will be high risk. If it is not broken, it will be low risk. Again, the blinding of the outcome assessment. Individuals responsible for measuring the study outcomes are kept unaware of which treatment group should participant belong to. Suppose I am a researcher, I am responsible for the outcome assessment of a group of data. Now, even I don't know the data I am receiving is of which group. Is it of the exposed group? Is it of the unexposed group? I have been blinded of the outcome assessment. I just have to analyze that data. So this would be the blinding of the outcome assessment. If this part is ensured, it will be low risk. If it isn't, it will be high risk. Up till now, is it clear? Okay, brilliant. I will tell you how you can use RevMan to make a graph of bias summary and quality assessment graphs. But up till now, are these 4 questions clear to you guys? Random sequence generation, allocation, concealment, blinding of the participants and personnel. Do we have to mention it in a table like Ottawa scale? I will tell you in the Ottawa scale, you have to manually make a table, but using RevMan, you can make a computer generated graph. Okay. I will tell you guys that step after namaz break. Okay. Now the other questions are incomplete outcome data. If in the randomized control trial, the participants have dropped out and there are missing follow-ups or appointments which make the outcome data incomplete. There is missing data or there's a great proportion of data that is missing, which can have a significant impact on the randomized control trial. So this will be a high risk. But if there is no missing data, or if the reasons for the missing data not related to the outcome, if there is the missing data, but that missing data has no effect on the outcome we are studying, or if the missing data balanced across both groups. If equal number of data is missing from both groups, again this will be low risk. Or the proportion missing or plausible effect not enough to have a clinically relevant effect. Again, if the missing data has no relevant clinical or plausible effect on the study, it will be low risk. Again, you can take pictures of these slides because again you will find exact statements like these in the randomized control trials. This is how you will make sure if this component of the quality assessment is low risk or high risk. In Ottawa, we didn't have these algorithms, right? We just represented it by stars. Yes, Sonia, Ottawa scale is completely different. The ROB tool is completely different. We give stars in the Ottawa scale. We don't give stars. We make sure we mention high risk or low risk based on the questions asked in each of these components. Are we clear up till now? I will give you guys example right after these slides, which will greatly help you guys in understanding whether there is which statement you will whether if an article has low risk or high risk about these questions. Again, selective reporting. If the authors are doing selective reporting, publishing only certain outcomes or findings or the results while neglecting any other outcome. For example, the researchers have done a selective reporting of the article they are doing the research on. This will create high risk. But if the article, there is a way that before even conducting a randomized controlled trial, you submit a protocol of that trial in a national healthcare registry or somewhere. So if the authors have done a protocol and if the protocol is available, that way they cannot do a selective reporting. And this will ensure a low risk of bias. But if they haven't done this and the outcomes are not reported as the pre-specified or as per the protocol, this will create high bias. Do you know what, do you understand Raya now what selective reporting is? All of these statements you will find in your methodology of the randomized controlled trial. Okay? Up till now, am I clear? Sharina, Sonia, okay. Now the final are other bias. Now other bias can include funding bias. If a certain pharmaceutical company is funding a trial, they will want to make sure that only selective reporting is happening. They don't want to address the undesirable effects of a certain drug. So these can be included in the other bias. So for example, the funding as such. Again, Hamza, Okay, so second point. In the selective reporting, if the authors are making sure that only a certain outcomes are reported while neglecting others, they aren't following their protocol. This will create high bias. But if they have mentioned they have created a protocol, pre-specified protocol before even conducting the study, and they are answerable to that protocol, and they are making sure all the outcomes are assessed, are reported, that won't create a high bias. That will create a low bias. Okay, again, now it's time for some questions. Okay, now in this I have taken this snap from a randomized control trial. In the randomized control trial, they have mentioned the patients were allocated using a computer generated random sequence. What does this mean? Is it a high risk or low risk? Low risk. Excellent, excellent, excellent. Investigators and patients were masked to allocation. What does this mean? Is it high risk or low risk? Excellent. All of you guys now understand how we do this. Well done. Excellent, all of you guys. Again, in this randomized and masking, computer generated random sequence work. Is it low risk or high risk? Again, well done. Participants, study staff, and investigators were masked to the study assignment. High risk or low risk? Well done. You guys did a brilliant job. Now, this question. Read it to me and tell me whether the sequence generation was low risk or high risk. Is it high risk or low risk? Sequence generation. Guys, I want you to answer low. Is it low? Okay. How do you know it? The risks are referring to the bias. Yes. Okay. In this, is the allocation concealment low risk or high risk? Is the allocation concealment low risk or high risk? Low risk. Low risk. Okay, brilliant. Is it clear to you guys how we do a quality assessment? Okay, brilliant. After the namaz break, I will tell you how we make this graph. So, when we are doing the risk of bias assessment of randomized control trials, we have to make these graphs. I will tell you how with Revman you make these graphs. We will give you a 10 minutes namaz break. After the namaz break, please come quickly. Don't leave the meeting, okay? You can have the namaz break right now. Okay, thank you.